Hi, Joyce. Thanks for calling in.
Oh, that's all right. No worries.
So, I guess the reasoning for this particular podcast is it was triggered because of the recent newspaper in the Australian Doctor that just published about opioid being a target, really, for the new target, I suppose, for Medicare to sort of get involved and look at things. And over 4,000 GPs have actually received a letter, which has triggered a lot of anxiety, a lot of anger, I suppose. And so I thought I'll bring you in and have a chat with you about your explanations and thoughts in regards to what's going on. Look,
Yeah.
I might just start with, if you could just explain to me a quick role of who you are and what you do, and just the norm of what a pain service is in the perspective of
Yeah.
a GP with a keen interest in pain.
Yeah, okay. So, look, this week has been a big week because I have received all these phone calls when the letters were being received by our GPs who collaborate very well. And there was a lot of anxiety in the air for sure. So my role, by background, I'm a clinical pharmacist, but for years I've worked very closely with GPs, and together we've collaborated in, medication review processes, education.
Mm-hmm.
I had the privilege of being able to design a health pathway, a healthcare solution, so to speak, for primary health specifically,
Sure.
for pain management.
Sure.
And the whole motivation for that was because of the lack of services around, the wait list for tertiary care. And I suppose the bigger motivation was both for the GP and the patient in the primary healthcare space. So really pain is my interest area, and I certainly, form a fairly niche expertise in that area.
Sure.
Yeah.
And I mean, overall, I guess the comment would be that would that mean that GPs who, I guess, collaborate with your services or any services that, does pain as a main modality would obviously be prescribing more, let's say opioids per se, compared to the general public or general body of general practitioners, do you think?
It's of course hard to say, but I think if a GP has a keen interest in pain, they do see patients who do come to them needing help.
Right.
And some of them coming to the GPs needing help, they're a complex cohort of patients already as it is, and some come with opioids wanting help.
That's right.
Look at other ways as such. The GPs who do it well, and the GPs who have this interest area definitely, start to look at ways to manage it other than with the drugs alone.
Correct.
But it's a process, yeah?
Yeah, so, and I guess, in that process, you would, obviously we can't, as clinicians, we can't just cut out opioids when they're opioid dependent. So that process can actually take, several months, many consultations, etc. Those prescriptions need to be monitored. There's certain, ways and systems that you and the GP would derive along with the patient to actually try and reduce it. I mean, we're certainly not conversing about, pro-opioids. Of course not. I mean, that's obviously not what we're doing. But I think, would you say that it is important to acknowledge the fact that some clinicians may have to be in a position where they're prescribing opioids for a certain duration of time, as long as they're complying with elements, I suppose, that needs to be complied with?
Yeah, that's right. And that's why they come to services like ours as pain program services, to give the patient other ways of self-managing, health literacy,
Sure.
understanding their pain, validating them. But see, even coming to a pain program as such, self-management is not an overnight process.
No.
And it'll take us time, 12 months, 24 months sometimes, to get the patient to that spot. So in the meantime, the GP who is landed with the patient, or where the patient, is wanting to seek that support,
Sure.
to know other ways, because admittedly the patient may have not known other ways, and singularly that's all they've been managed
Sure.
as such. And some even don't know coming to the GP that there are other ways because they've been just simply given the medication for so long.
That's right.
And it's only the GP perhaps that's disclosing to them that, hey, there are other ways, I can collaborate, so it's better for you in the long run. But it takes a long time to change that sort of thinking for the patient.
That's right.
A lot of support. So, initially those GPs may end up having to prescribe, the higher amounts as such, because that's what the patient came in on. With the negotiation, I suppose the important thing, there is that all the documentation are, abide by, they might do things like the GPs who have special interest in pain, and really any GPs who's prescribing opioids should do this, but the ones particularly more astute in this area will be, using opioid contracts right at the beginning.
Yeah.
But the contractual process is not, if you don't do this or do that, you're out, strike three, gone. I think it's the understanding for the patient of, look, this is my obligation to you to keep you safe.
Sure.
Now this is your responsibility back to me.
Sure.
Keep us having a good working relationship together. That kind of validative process.
And I guess from your experience, you would say that a majority of, the doctors that you're aware of that's received this letter, I suppose, are pretty much compliant with these sort of systems and processes in place to ensure patient safety and ensure compliance. And I guess what I really wanted to ask you was, what has been your experience with recent, GPs that you've come across who have been, successfully collaborating, giving good patient outcomes, so forth, who gets these, notices?
Yeah, the problem is no word of a lie. All the patients who have rung, all the GPs, who have rung me this week are essentially GPs who have made more effort than I can, more time spent on these patients and actually getting some outcomes as such, meaning that, the change of behaviour in the patient's starting to come. I mean, we're not talking about massive opioid reduction, but we certainly are talking about opioid reduction,
That's right.
At least the direction is right. And the frustrating thing is they were actually getting quite empowered by doing systematically all the things the right way, not rushing, obviously, because otherwise you'll lose the patient. The patient will just go back out into the great ether and merry-go-round.
Sure.
They were pleased that the patient was actually, the turn-up rate for the patient was high, meaning they can follow on with the care.
Yeah.
And then, unfortunately, several of them were slapped with the warnings, and I think, everyone's human, and it's certainly given them a bit of a knee-jerk, almost I've tried so hard. Oh, why am I trying so hard and taking on these tough cases? I mean, some of these patients I have personally referred to these GPs to go, look, we've picked a patient up who is literally merry-go-rounding.
Sure.
They admit to doctor shopping. They will collaborate if they find that someone will,
give them a chance.
Take the hard road with them and give them a chance. And admittedly, they've stayed at least with the GP, and they haven't disappeared somewhere to show up again.
That's right.
2 months, 3 months down the road without further care or further progress.
Sure.
So these are GPs who have literally bent over backwards to go, all right, as long as we're working collaboratively, sure, all right.
Let's accommodate this.
Yeah.
And I guess you would say that these the patient population that these GPs are dealing with would be one of the most vulnerable, I suppose, because they're obviously vulnerable to to the potential tolerance and addiction and other ramifications it has of chronic pain as a disease. I mean, what at the end of the day, what do you think would be the immediate concerns for your services and more so for your patients because of this?
Well, the immediate concern is obviously GPs being naturally and very normally worried for their own self, for their own integrity, for their own, legal implications.
Sure.
And I suppose the worst part is if they do stop seeing the patient as such. I mean, one of the problems with, not say problems, but one of the I think, quandaries are typically these GPs whom we do engage with are the ones who will not stop seeing the patients because they feel that their legal obligation is not to leave the patient
That's right.
unhelped, you know.
That's right.
So I suppose these GPs will be practicing under great anxiety, great challenge, great stress. And obviously they do need a lot of support. This week has been a week of supporting GPs. We have looked through cases with them, and that's not just one GP. I have spent last weekend as I started to get more, you know, phone calls about this.
Yes.
We've re-looked at our own books to go, hang on, you know, we have engaged patients who are attending education programs, some
That's
of them,
right.
some not, you know. But those who are definitely compliant. Okay, so we look through all of that, you know, and we look through, is it rationalisation of use?
That's right.
As such. So we've tried to support GPs that way, but it's taken a lot of time to not just do our own caseload, but
to actually look through that as well.
Yeah. So we've done our own re-look of our own due diligence as well.
Of course you would, yeah.
To make sure we're serving the public the best we can and as safe as we can.
Sure.
And it doesn't hurt, absolutely not, to have a second look at things because time is always, you know, poorly upon us.
Sure.
So we have, I suppose, the other implication I'm concerned about is also, you know, the stress on our service in terms of, sure, GPs need support, so therefore they'll refer some more, which is fine.
Sure.
But, you know, that is pressure on our service. At the moment, we can absolutely cater for it, but there is we have to all agree that, I mean, ours is a very specific primary healthcare service. Tertiary services are already at wait lists of, you know, minimum 6-8 months. Some less, but depending on the categorisation. So we're kind of available, but we're not duplicating by the
of course.
You know, by the amount.
It's very limited,
Yeah, that's right. That we cater for these 4,000 letters that have gone out.
That's right. And I guess in that point of view, what concerns me as a clinician as well is, you know, if these, because going through this experience myself, I can tell you that the first thing, you know, you think about is, you know, of course, your patients, but secondly, your ability to continue billing or prescribing these sort of items. And knowing what I've actually personally gone through and knowing the vagueness and the inconsistencies of these inquiries and how it's actually triggered, it really does worry me that, you know, doctors would actually, as a matter of fact, I've received, you know, a lot of inquiries from my colleagues who are going through these that are saying that perhaps they're just going to try to see if they can, you know, remove themselves from prescribing at all because they're in fear and in anxiety of losing their ability to bill or the ramifications of going through, I guess, what I've gone through or what other, you know, doctors have gone through in regards to these audit processes. As there's really, as we discussed before, there are no standards or benchmarks that we all agree to that this is absolutely fine. I guess where to from here, Joyce, you know, just to conclude is, you know, I really, the worst thing that I think doctors would do is to withhold care for their current patients, because essentially that's going to jeopardize the welfare of their patients. But in saying that, I think it's really important for all of us to acknowledge the importance of making sure that the compliance is in place, like what your services is providing for the doctors, to make sure they look through their, you know, paying patients and, you know, they've got their contracts and, you know, notifications and optimizations there.
Like opioid contracts, opioid risk tools, you know, have those forms at least completed. And then maybe even, you know, a patient self-report, self-functional form. There are those forms to show that there's either improve or change of function as a baseline measure for their opioid use as such. So, you know, having some measures that actually evidently shows that, you know, letting the drugs of dependence unit know that you're the prescriber, ringing doctor shopping hotline. But there's a lot of work up in that, I suppose, as well, which is absolutely just necessary. But at the moment, you do have to do that due diligence. Reach out to clinical pharmacists, perhaps in the community, who are perhaps able to visit the patient at home under the Home Medicines Review Scheme, or, you know, refer to a pain clinic as such, but obviously, you know, for